My name is Jay Granzow, and I'm talking on the importance of using an integrated system of surgery and therapy to treat lipedema. I am a board-certified plastic surgeon on the full-time faculty at UCLA, and I have a small private office separately in Manhattan Beach to help treat the patients. Kev, no financial disclosures. Key points I'd like to make, and again, I'm going to go quite quickly. The slides, I think, are going to be videoed also, but the different lipedema patients require different treatment approaches. So there's not one specific way to treat everybody. As you know, everyone has a different presentation, and so everyone needs to have a customized treatment plan, and we spend a lot of time going over that to really go over the goals and the expectations and what we can accomplish and what we can't. We think the best results are achieved when the surgery is performed by an experienced surgeon as part of an integrated treatment system. It's not about me or about one procedure, it's about the whole process and what you can do to get better. Options ranging from a surgery center to hospital must be available, so smaller areas or a surgery center local for smaller problems usually, and then bigger problems might require a hospital, general anesthesia, etc. We have access to both of those things, and we think that those are important. That is very important. And finally, and also very important, is because lipedema may overlap with lymphedema, the surgical team has to be experienced in treating both. If you try and treat lipedema, just lymphedema as lipedema, you'll have a lot of problems afterwards. So here, very important, this is, again, it's not about me or surgical process, this is about the team that we use. All the special people that come in contact and are integral parts of what we do are very, very important, and I absolutely cannot function without each and every one of them. And so I really applaud everyone who works with me, both in our office and in our hospital too. And here I applaud this little group the most. It's my family, and they've put up with a lot with me, working pretty hard and going and giving talks and lectures. And we've actually, I'll go over it a little bit too later, but with our daughter, we've had a bunch of personal issues with disease process too, which puts me on the patient side a little bit in a rare disease like lipedema also. And so the first thing is that lipedema and even lymphedema therapy are critical before, during, and after the surgical process, okay? When we, and proper patient evaluation is key too. So I like to spend an hour with a new patient. Our therapist spends an hour, our office spends additional time, my PA spends additional time. We really want to get to know that patient because we're going to be spending a lot of time with that person before, during, and afterwards to get them their best result. And I think Polly hit on that very well too. We really want to get to know you and get to know what the goals are and what we can and can't accomplish. Again, patient selection is critical. So how do we accomplish that thing and what are we trying to do? Those are very, very important goals to have. Okay, I think here there are very few, or I don't think there are any surgeons who are not experienced with lipedema, but suffice it to say that the treatment of a lipedema patient, and especially a lymphedema patient, lymphedema is much harder to treat than lipedema, is something that should be done by someone who does this on a regular basis, not just a cosmetic surgeon who maybe has a downtime and is doing an off case. This is from Plastic Surgery News, so this is all board-certified surgeons get this thing. This was from February 2009, depth of the recession, and this guy's cosmetic practice is falling apart, so he should be doing a few extra reconstructive procedures on the side to keep his office going. And so we don't agree with that process, and I think that's important. So lymphedema surgery, my background again comes through microsurgery, complex reconstruction, and then also lymphedema treatment. I think lymphedema surgery is actually a lot harder than lipedema surgery for a bunch of technical reasons, but we have a process for lymphedema too, and it works and it's consistent. Here, this is a patient, hard to treat, chronic lymphedema, 46 years, had a big surgery with the scar that went up and down the left leg. And so this is a 9-month result, and this is what we can typically expect to achieve with most patients, and here's a 21-month result. So we can get, if you use a process, you can get very nice results for patients. I know where the lymphatics are because I also do microsurgery, moving lymph nodes around if needed, getting at the lymphatics to make them better. And so here, for example, I might know that lymphatics or lymph nodes can be taken from the green spot, but definitely don't take them from here because we don't want to have a problem. So again, when we apply this to lipedema surgery, we can be safe. And how we use the tools at our disposal rather than hey, there's a water jet or there's a vaser or there's something or the other. We have a powered machine, but again, and I have data that I'll show later that we can get those very consistent results also. Okay, here's a lymphatic vessel, and again, I can talk to this too because this is a vessel that I sutured to a vein in an LVA. This is a 0.3 millimeter in diameter vessel sutured with an 11-0 suture. I know where these things are so we can avoid them. Yeah, so very small. This is a very high-powered microscope. I actually have to modify the eye microscope. I can't use a normal one. So we can go and get those things. So going down to lipedema surgery, again, if we use a system, it's not just one isolated procedure, throw you over the fence and be done. We can treat patients with a large volume or range of volumes. So here, we've done one procedure. These are all one procedure. One procedure as little as 500 cc's, and we've safely done a procedure over 10,000 cc's. Okay? If this were a cosmetic patient, that would not be safe in my opinion, but we can do it with a tourniquet in the hospital. There are ways to do it that are very safe and very, very effective. Okay. And again, if I need to image the lymphatics, I will, and we know exactly where to find them and how to avoid them too. We try and be as evidence-based as possible and very compulsive, so my lymphedema therapist will actually take volume measurements, and we measure these before and after, put them in the computer, and we can tell you how much volumes actually come out of your limb before and afterwards through the measurements that we take. Again, the procedures are important and the selection is important. We don't want to use just one hammer to hammer all the nails, so we do adjust what we do each time. A little bit on cosmetic liposuction versus something sapple aspirate, which is for lymphedema. So cosmetic surgery, you're going to typically get some fat that comes out like nice custardy, sort of yellow, smooth. And the stuff that comes out from lymphedema is more like curdled milk. Lipedema is somewhere in between. And so these two things are different, and we have to know how to handle those things. So because lymphedema can be present in the same patient as lipedema, we often do get some extra studies such as a lymphoscintigraphy. We might do mapping or imaging during the procedure depending upon the patient to do that. And because the therapy and the treatment for lymphedema and lipedema are quite different in my opinion, and we have to handle those differently too. Something that's been brought up again in numerous lectures previously, and I'm very happy with that also, is that there's often an obesity or morbid obesity component with the patients that we see. And that needs to be addressed also. And that's a topic that needs to be addressed almost in a separate way, but together in the overall treatment plan. And so that can't be avoided. We know that obesity actually can cause lymphedema. This study here, BMI over 60, all the patients had lymphedema. When it went down below 50, a lot of them got better. And we know how this happens. This has also been studied in the literature, at least. There's a predictable pattern of sclerosis of the lymphatic vessels. Again, I'm going fast because we have limited time, and that's been known. So here's a patient, this gentleman comes here. He's got lymphedema, but that's because of the excess weight. Okay, so there's a great therapist in our area who sent him over. This is just therapy. So not every patient needs surgery. And also patients that are very heavy, so the heavier the patient, the more risky your surgery is going to be. So we really need to think about treating that as well as treating the lymphedema too. Not all, and so the heavier patients can also maybe not be a surgical candidate, depends on the case. Okay, lymphoscintigraphy, sometimes we do this preoperatively. So here's a straight lipedema patient with no backup of lymphatic tissue. Another one, lymphedema patient with some backup, so some lymphedema on top of lipedema in the lower leg on the right. And then this is somebody who's clearly got lymphedema backup in the lower legs there. And so all these patients need to be handled differently. We can do MRI scan imaging if needed. This is the left leg and the right leg on the same patient for the thigh, through the thigh. And again, this is how something like that might look on an AP view. And that's how the patient might look there. So this is what you see, and that's how the MRI image would have looked. Okay, so liposuction surgery, so that's what we call our technique, liposuction. They want a service mark above that, that's fine. But bottom line is that we can do this. If there's a bigger patient, we put the patient completely to sleep. We can do that, so the patient has no pain during the procedure, might even use a tourniquet, and we can get a large volume off very safely in one shot if that's the appropriate thing for that patient in a very safe way. I know, how do I know the lymphatics are spared? Again, I have a power assisted machine, but it's not water operated, it's not a Vaser or those things. The treatment gets better. If they have lymphedema, the therapy gets easier, and we can image it. Here's an here's an imaging of indocyanine green before and after. Now those black lines are the pen marks, and so like Mike Burness was talking about this morning, you can actually see the lymphatic, the tissue move through the lymphatics when I'm marking those things. So this is a before and after with some pen marks on the top. And sometimes the lymphatics are quite burned out, but those even do seem to improve in many of the patients, even for one that doesn't look so good before. Again, therapy is critical, even during the procedure, so we might actually have the therapist, and often do, have the therapist come and put a bandaging straight on the leg to keep the swelling down right in surgery. We found this very effective. We put a compression garment on afterwards, custom fit from Germany if needed, and we keep that swelling down because that swelling is a bad actor. There's going to be inflammatory fluid that'll hurt your result. And a couple of case studies here to round out. So this is a patient with an earlier stage lipedema, and we get an improvement here. And again, what the pictures don't show is how much better the patient feels. So the pain often goes, or usually goes away right away. This is the posterior view, same patient. And then here's a patient with a bit more advanced disease. And again, same thing where there's an improvement, although you can't see how much better she's gotten, but she has with the pain. And so posterior view as well. So finally, I just want to end on a bit of a personal note. We've, education, as far as a provider, education has been the most difficult thing to do. I think we have a great process that works consistently both for lipedema and for lymphedema, and coming out and being able to present to a group is really important to get that word out, because a lot of times the physicians, don't know, they misdiagnose things, there's a delay in diagnosis. How does this relate here? Well, on a personal level too, our 2-year-old daughter, well now 2, has had a lot of issues for a long time. Delays, seizures, et cetera, and it took a long time to find out what was going on. And so just like maybe our lady from Jordan, it took multiple physicians, nobody knew what was going on, and I'm a provider, so it's really frustrating. Finally, we got this diagnosis, and we even given information that wasn't quite right too. Like we were told, well, she'll never speak, she'll never talk, she'll never write, she'll be mentally handicapped, and have seizures forever, and there's nothing you can do about it, and there's no treatment permanently that will be available. What happened is that's all not true, because and it's hard to know that, and I think that really is analogous to seeing a lot of the patient stories that we have here, because actually we had gotten quite aggressive with therapy, and it's helped. She's walking at 18 months, where the average age is 3 years for someone who walks to 5. We know that she's said a few words, things are going forward, and the seizures have been controlled, for example, with diet, which is a low glycemic diet, which I know has been talked about here before too. And so these things help, and I think I'm really happy for Cheyenne and Felicity and everybody else too who's been able to put this organization together, because for us, we found that we've gotten the most good advice from other families and the organizations that are associated with that thing. And so again, I think here, having a good group, having your peers, and having everyone else together with this will really give the best advice to be able to find the best treatments, whether it's therapy or surgery, whatever, and really listen to those people. And certainly, this is something that we're very glad to share, and we're very happy to share too. It's been a lot of effort, so I haven't been around as much as maybe I would have liked to, but at the same time, it's something where come up and talk to me about whether it's this, but also just about lipedema surgery. And it doesn't matter if you come to me or not for surgical treatment. Again, we want to take care of you like you were family, but certainly it's something where ask around and find out who's good for the information. Thanks very much.